Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators AOGME webinar series. We're pleased to have you join us for this AOGME webinar on moral injury featuring Dr. Shibby Abraham. My name is Austin Wetmore. I'm the program manager for GME initiatives at ACOM, and I will help facilitate this webinar. Before we get started, I would like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage shortly. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for Dr. Abraham during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, Dr. Abraham will respond to your questions. I will now briefly introduce our presenter. Shibby Abraham, MD, is a board-certified adult and child and adolescent psychiatrist. She currently works at Catholic Health's St. Catherine of Siena Hospital, providing mental health services for patients in the ER and on the medical floors. Dr. Abraham is also the program director for the psychiatry residency program being established at St. Catherine of Siena. She has a passion for academia and is an adjunct clinical assistant professor at NYITCOM and teaches medical students and residents at Catholic Health. Dr. Abraham completed her residency in general psychiatry at Jamaica Hospital Medical Center in Queens and a child and adolescent fellowship at Mount Sinai Elmhurst. She has also served as an assembly member for the American Psychiatric Association for the last 8 years, and she is currently the early career psychiatrist representative for New York State. She is the past president for the Queens County Psychiatric Society and worked toward mental health awareness on the district level. She is also involved through her parish, St. John's Martoma Church in Queens, in promoting mental health wellness for youths and young families. Thank you again to Dr. Abraham for being with us today and for preparing this presentation. With that, I will turn it over to Dr. Abraham.
Hello, everyone. Good evening. So again, my name is Shibby, and the reason why I chose this topic, which I'm going to share my slides soon, is because there's been a lot of, I guess, confusion or understanding moral injury and burnout, even for myself. I was also considering burnout, especially during the pandemic, to identify some of the things that I was feeling inside while working. And as I started to look into it more, moral injury is something that's been there for years. And I've read about it in residency, but I've always associated with military. I never thought about it with physicians or even clinicians, until there was an article that was by Dr. Dean, Wendy Dean and Dr. Talbot, and they started bringing it about into, I guess, the community and everywhere else. They published the article, and then doctors started to become more aware about it. Physicians started to identify, even other people who work in the clinical field, they started to identify that, this is not just burnout, it's something beyond that. And that's when I also started talking to colleagues. And when I did a talk in our GME for the graduate medical education, it was just to bring that awareness, to identify that sometimes it's not burnout, because physicians feel like we don't feel like we identify with that. I was recently at the American Psychiatric Association, and I attended that, and I heard some of the psychiatrists even there, the physicians, describing what was really moral injury. But they were describing it as burnout because we had the US Surgeon General through a webinar there, and he was listening to all the issues and concerns, and everybody was addressing it more as burnout at that time. And I was listening to it, and I said, oh my goodness, this is what she's describing about the issues in our hospital, the administration, the constraints, all of that was really moral injury. The second purpose of this is not that we are separate. A lot of times when I talk to physicians, they feel like it's separate, that it's an issue with physicians and administration. And I don't think it should be that way. We're all working together in a hospital to what's the best benefit. We're supposed to do what's best for the patient, but also for the hospital, right, that employs us. So I think it's something that needs to be worked together with the administration. When we talk about moral injury, it shouldn't be all that administration's bad and it's all against them and this is the problem, because we'll never get anywhere. Part of it is working together with them, being able to communicate, addressing these issues, and hopefully they're listening. And I've talked to some people who are doing, trying to figure out what they can do with administration. And part of that is listening, not just, it's hard, but listening to different specialties, seeing what the issues are with each specialties and what they can do, because they can't solve every problem, but making those initiatives and beginning that is the first step of change. So with that, I'm going to share my slides, a slideshow. And okay. So again, the objectives, as I mentioned, is differentiating between burnout, moral distress, and moral injury, understanding the effects of moral injury in healthcare, and reviewing methods to prevent and address moral injury. So I took this directly. This is a quote. I loved what she wrote. It's from Wendy Dean, the person that had written, the psychiatrist who had written the article that I talked about moral injury. They kind of brought it into light with everyone. So this oath, I think it can resonate with all of us. We take an oath. Everyone who leaves medical school takes an oath to put our patients as a priority. Our patients come before we eat, before we sleep. They come before our kids' birthdays and anniversary dinners. They come before almost everything. When we are asked by corporatized medicine to take care of something else as a priority over our patients, it tends to electronic medical record, the insurance company with prior authorizations, the hospital's need for volume by seeing more patients in shorter periods, it strikes at our deeply held beliefs that our patients come first, the thing that was ingrained in our training for the past decade or more. And I think she hit it on the nail. When I read this, I said, this is exactly what's happening in medicine. And this is why physicians are starting to feel like they no longer want to practice in a hospital and they want to leave. Some people even want to leave medicine. And this is what I think she said exactly how it is. So before I go into more moral injury, I like to usually go into more of definitions so that we kind of understand what each one is, because there's a lot of terms out there and that's been there for a long time. So some of these terms, the first one we're all familiar with is burnout. And this was coined in 1970s by the American psychologist Herbert Freudenberger. And what he said is there's a continuous long-term exhaustion. So you're exhausted and diminished interest, especially in one's career. It's the final consequences of unmitigated moral injury and drives people to addiction, therapy, or career change. So this can impact one's sense of engagement and efficacy. So in here, what I highlighted, or what I would like to highlight, is that it leads to exhaustion. And that's what burnout is, exhaustion and diminished interest in doing what you like to do. PTSD, the term post-traumatic stress disorder, it came into use in 1970s, in large part due to diagnosis of US military veterans of the Vietnam War. And we know what this is. It's more of PTSD, it's a mental health condition characterized by prolonged stress response to a prior traumatic event. So they're always in combat, but it lingers on, it stays with them, right? It predominantly impacts the sense of safety. Compassion fatigue. This is something that's called on running on empty. It's sometimes referred to as secondary traumatic stress. It was coined in 1992 by Carla Johnson to describe the negative impact hospital nurses were experiencing as a result of their repeated daily exposure to patient emergencies. This leads to burnout. So this is when the nurses, what they said in there was that, normally when you see a patient and suffering, not that you care for them, you take care of them, but when that daily exposure is so much that it just becomes something routine, you lose that empathy in you, that you feel empty. You just see a patient as just another person that you need to get through the day. And that is compassion fatigue. Next, we come to moral distress. Moral distress in 1984, it was first conceptualized by philosopher Andrew Jameson in his book on nursing issues, nursing practice, the medical issues to describe the psychological conflict nurses experience during ethical dilemmas. He wrote that moral distress arises when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. So this is very similar to moral injury, but this was first identified with nurses when they were going into it, and moral distress eventually leads to moral injury. And that is the difference, that as it is sustained and chronic, it becomes moral injury. And when moral injury is persistent, it becomes burnout. So that's why it's very important to intervene when you identify moral distress. And moral injury. So we come to moral injury. And this is, the term was coined by 1990s by a psychiatrist, Jonathan Shea, and colleagues based upon numerous narratives presented, and it was really for military and veteran patients, given their perception of injustice as a result of leadership malpractice. Shea's definition of moral injury had three parts to it. The first part is moral injury is present when there's been a betrayal of what is morally right. And this is why you can see why it was now applied to physicians and other clinicians, because you know what you're taught. And when we take the Hippocratic Oath, what we're supposed to do for the patient, but there's a betrayal by people that's around us, maybe of a position of authority or high stakes. So that's the second, by someone who holds legitimate authority and in a high stakes situation. This predominantly impacts the sense of trust and or self-respect. Moral injury in military is the offense of, and I think there was a question that was asked in the beginning of, before that was given to me, and this answers that question. How is it different? So moral injury in military is the offense of killing another human in the context of war, so in combat. While in medicine, it's being unable to provide high quality care, as we said, putting patients first, and healing in the context of healthcare. While PTSD might be caused by a threat to one's mortality, moral injury is caused by a threat to one's morality, of our sense of self, of knowing that we feel we did the right thing, the good that we feel inside. When we walk out feeling guilt or we feel betrayed, that's when there's moral injury. So now this is the second author of that paper, Dr. Talbot, and he said, most physicians enter medicine following a calling rather than a career path. They go into the field with a desire to help people. Many approach it with almost a religious zeal, enduring lost sleep, lost years of young adulthood, huge opportunity costs, family strain, financial instability, disregard for personal health, and multitude of other challenges. Each hurdle offers a lesson in endurance in the service of one's goal, which starting in the third year of medical school is sharply focused on ensuring the best care for one's patient. Failing to consistently meet patients' needs has a profound impact on physician well-being. This is the crux of consequent moral injury. And I'm going to let that sit with you while I go to the next slide. So moral injury is a violation of deeply held values, and this can shake the core of an individual's identity and self-concept, how we see ourselves, how content we are with ourselves as a physician or clinician. Moral injury may result in a range of feelings such as guilt, shame, anger, grief, anxiety, and disgust. Self-loathing, existential and spiritual crisis are also common. Some individuals may develop physical illness or maladaptive behavior, substance abuse, self-isolation, and we come later into about even suicidal ideation, depression, and so forth. So I want you to think about this. This is a scenario, and this is a real scenario. Imagine a soldier that shoots dead a child whose body is laden with explosives. How might the soldier feel on returning home and holding their own children? So I want us to put ourselves in that situation and think about that. That here is a soldier who has to kill a child because there's a bomb or explosive on them, and they are almost like they have no choice. And then they come home and they hold their own children. What do they feel? There's a questioning that goes on, right? Did I do the right thing, killing that child? Here I am holding my own child, but and over there, I killed another child. And even though we know, yes, obviously in that situation with the bomb, there was nothing more they could do, but that sense of morality. Soldiers, they feel they're there to protect, and here they killed a child, and then coming home, what they feel, that guilt, the shame. And that's how one of the scenarios for soldiers, what they feel in combat for moral injury. This kind of act is a violation of what is right, and is reflection on you as a good or bad person. Because as humans, we tend to do that. Are we good or bad? For most people. The betrayal of what is good fractures moral identity. It's these kind of events that lead to moral injuries. Now, medicine, although not in that same scenario, is very similar. It's intimately connected with human well-being and operates at the fringes of life and death, right? Physicians always make these choices, which sometimes, many times could result in life or death choices. Inevitably, doctors witness a range of human pain, hardship, and misfortune daily. Moreover, what doctors do, fail to do, or see others doing, and how this affects patient care and outcomes could be perceived as a grievous moral transgression. This all threatens a doctor's moral identity and can leave them susceptible to moral injuries. But how does this line up with what we mean when we talk about burnout? And that's where I'd like to go more into the difference between burnout and moral injury. So before I go into that, I was actually read a lot about moral injury and attended different things about moral injury and heard different aspects about it and the studies that's there now that there's more coming out. But I recently went to the APA conference and in San Diego, and there was a presenter. Her name was, she's a psychologist, Karen Maker, and she did this article about healing moral injury, developing moral resilience. And she brought this concept that I was like, wow, she's right. I didn't think about it that way because we're always learning. This is something that's coming more new for physicians. And she talked about resilience versus integrity. And this is a key point. So I'm going to go into the definition and explain it. So integrity is the capacity to live out a life that is sufficiently consistent with one's values and commitments, facilitating a sense of steadfastness, authenticity, or wholeness to one's sense of self, being true to yourself. Do you feel that when you walk out of your hospital, seeing the patients that you do, that you feel like you did what you felt is best for the patient, not what the hospital felt or what anyone else felt, but you felt was the best possible care and treatment for the patient. Moral injury compromises our integrity. And that's what she pointed out. Resilience is with burnout. Moral injury is with when there's a problem where it affects your integrity. When that's compromised, a physician's integrity, it leads to moral injury. Resilience, on the other hand, is the capacity to adapt swiftly and successfully to stressful, traumatic events and manage to revert to a positive state. Burnout compromises our resilience. Now, don't get me wrong. Physicians can have both. You can have burnout and moral injury, especially with the high volume and turnout, and we keep seeing patient after patient and what's going on right now. So all of that, you can have both, or you might have just one or the other. I've heard some physicians say, I've been through med school, I've done through all this stuff, and yes, residency, and they're right. You've been through some of the worst things where it challenges you, especially in residency, right? With the resilience, you've learned how to adapt swiftly. And some people cannot, because depending on where you work, how the volume is there, state to state, everything is different. But when it comes to moral injury, what they felt was it's on my integrity. What I felt is right, and I'm not able to do that. There's so many constraints around that, so many limitations and restrictions. They're no longer in control as a physician. It's almost like you feel like a puppet being pulled at different strings. So burnout versus moral injury. Burnout is a group of symptoms that cause exhaustion, cynicism, and decreased productivity. And a lot of times we see this a lot with medical students, residents, and even physicians. The concept of burnout doesn't resonate well with physicians, as it suggests a failure of resourcefulness and resilience, traits that most physicians have finally enhanced during decades of intense training and demanding work. That doesn't mean, although I've read this, I still think a physician can be prone to burnout too, easily, because of the demands and pressures that's there. Moral injury occurs when medical professionals have the ability, knowledge, and know-how to help a patient, but are unable to do so because of systematic failures. They are two different things. And the systematic failures prevent the care from happening. In other words, moral injury exists when a doctor feels that the system is causing harm to their patients and colleagues, and they are helpless to prevent it. This phenomenon causes profound moral disorientation and emotional trauma, which is different, distinctly different from burnout. So moral injury is an injury to individuals' moral consciousness and values, and produces, as I said earlier, guilt, shame, betrayal, anger towards colleagues, commanders, organization, politics, or society at large. And what this does is that it ends up leading to that silent quitting, right? That's what's been going on. They're fed up and they just walk out or leave and put their resignation in. Moral injury and burnout have different causes, are experienced in different ways, as I mentioned. Now, causes for moral injury, I've mentioned burnout, are mainly recruitment and retention challenges. I think we've all might have felt at some point that I'm feeling it right now. There's not enough staff, whether it's the support staff that you have, or whether it's your own colleagues, not enough and covering a lot more than you have to. For our situation, because of things that happen, we have enough, but it could be someone getting sick. It could be people just, with multiple vacations, sick, everything happening same time. And sometimes that's the problem. When there's recruitment, retention challenges, lack of protected time for supervision, teaching, mentoring, especially when you're involved with residencies or even just teaching and still having to see the same amount of patients and do the same amount of work, how do you break up that time that you don't have? But yet, if you have a passion for teaching and you want to be involved and do that, how do you do all that? So inequities in subsidized medication, cost prohibitions, racial and gender diversity among staff, and lack of administration. These are some examples that can lead to moral injury where you feel like the system has failed you. When a system overturns a doctor's sense of right and wrong, they suffer a moral injury, not burnout. So when you have that sense where your right and wrong is impacted, moral injury. When you feel exhausted because you feel exhausted, tired, that's burnout. The system may cause burnout, and that's important to understand, which we know, and I explain how. But when the system impinges on the doctors acting according to their conscience, this results a sense of despair is closer to moral injury than burnout. And even if they can share similar causes, the two remain very distinct in that burnout is emotional and it can have physical exhaustion with his sequelae, whereas moral injury, on the other hand, is intense distress, feelings of shame, guilt, or self-loathing. So right after, during that pandemic, there was a lot more of people, doctors and clinicians, and you'll see that one of the highest we've ever had is right now, where physicians are leaving their profession, not only leaving the hospital, it's hard as it is now in the hospital to find someone, but leaving their profession. So in the early 2020s, moral injury emerged as one of the explanations for the wave of employee resignations across industries. So as a psychologist, Parsalova, who proposed that moral injury might be a better explanation for a segment of resignations and employee distress than burnout. And since you address these two different ways, there was some suggestions made for organizational level interventions. So what they saw is that healthcare, and we all agree with this, I think, most of us, I shouldn't say we all, is becoming more business-oriented and profit-driven, wherein physicians must consider a multitude of factors other than their patient's best interest when deciding on treatment. Number one, financial considerations, right? Number two, electronic health records. Everything now has to be dictated, documented, every single thing. We're spending more time in the charts than we are with our patients. The anticipation of litigation. Now, everything is like you're going to get either sued or they're going to come after you. Everything's like this. As I get to the next one, satisfaction scores, everything's going to come back at you. So you're constantly worried about that, documenting it in a way that you're protected. At the same time, all of this takes away from why we went into medicine in the first place. Spending that time with patients, treating the patient. We're treating charts more, we're treating other things more. So patient satisfaction scores and provider rating and review sites, I think we can all talk about this, right? If a patient's just upset because you didn't give them what they wanted, even though you know that's not best for them, for example, benzos, opioids, in those cases, suddenly they go out, put you a negative score, or go to patient advocacy, complain, give a report. And what I've seen is that, and not everywhere, but is sometimes the way that's being approached is not that, let me hear your side as a physician and let's see what we could do, but can you fix it? The patient's complaining. They're putting a bad score on the hospital, bad score. Can you fix it? Can you just do it? Take care of it or do it. So there's no support for the physician. It feels almost as if we have to do everything to please everyone else. And then, of course, referrals to their own system. Sometimes it's like send them to some hospitals or facilities will say, make sure it's sent within the hospital, even though you might know a different provider or a different place that would be better for the patient's care. So addressing burnout. There have been many models that have been proposed to alleviate the nature of burnout, like the multifactorial nature of burnout, like the one in Penn State. That was from Maslow's hierarchy of needs, and I will go over that briefly. So when Maslow did that, they created a wellness hierarchy for health professionals. It's shaped a similar way, like a pyramid. The base of this model states that physicians must first take care of their basic physical, and this is for burnout, basic physical and mental health needs before anything else can be corrected. So taking care of your own needs, physical and mental, which is different from moral injury. Then only can you move on to a higher need like appreciation, respect, ability to contribute meaningfully, eating, drinking, sleeping, taking care of their family. I think it's really sad that we need a pyramid that tells us how to be well. And that's what it's come to, which is very sad. So the basics on this for burnout is that, am I hydrated? To make sure you're drinking fluid, access to food, time to eat, enough sleep. I don't even think we should have to be in a situation like that, where you have to ask yourself, although it's there. I actually asked myself that today. I didn't drink any water until I came back in the afternoon. And I said, oh my goodness, I have to keep drinking water. But that's where it is. We're so busy seeing patients and taking care of everything, we can't take care of ourselves. And we need a model of a wellness to ask ourselves, did you eat food? Did you sleep? Did you get enough sleep? I have no depression, no anxiety. I'm free from substance. I have no suicidal thoughts. I have time to space to breastfeed. And that's basics. And then you move to safety, which is that you're physically safe, your patient's safe, your future job, then respect. Do you feel there's enough respect? You're not hassled by different things. Appreciation, you feel noticed and appreciated, because if you don't have basic needs met, you can't even go up that ladder. And the last one is heal patients and contribute. Then only can you heal patients and contribute. And this is that burnout model. And like I said, I think it's a sad state that we're at this point where we have to start checking in ourselves to make sure, but we need it to make sure we are fine instead of putting everyone and everything else first. It's like I tell sometimes my patients, there's somebody that they're taking care of their families, they're taking care of this, and mental health, right? It comes on, it's mental well-being. And I tell them, and even when they're being admitted to inpatient psych unit, they're worried about their family. They're worried about how am I going to take care of what are they doing? My job. And I said to them, if you are not well, you cannot take care of anyone else. You cannot take care of your family. You cannot take care of anything else if you are not well, because if you get sick and you fall, that's all going to fall. And the same way with physicians. So this was from the US General Surgeon. So there's a lot of, he actually recently put some reports out too, and he's really focusing on workforce, mental health and well-being in the workplace. And he's really looking into that, but a lot of it is burnout. And I think now they're seeing the moral injury. So that's also coming into play. So initially, this is really more, although the framework said this was mainly addressing burnout, but there was a lot of things from here that we could use in moral injury as well. So one is, of course, protection from harm. So creating the conditions for physical and psychological safety, that is critical foundation for ensuring mental health and well-being in the workplace. It assures protection from harm. So these things are prioritizing workplace physical and psychological safety, having a safe space. That's basically what he's saying. Enable adequate rest, normalize and support focusing on mental health. Don't stigmatize it. I'm going to talk about that a little later because it's unfortunately still very much stigmatized, especially among physicians. And then, of course, the programs to operationalize diversity, equity, inclusion, accessibility, all of that, policies and programs. The second one is, and so that's all feeling safe in your workspace. The second one is connection and community, fostering positive social interactions and relationships in the workplace. So support, feeling you're supported and you can connect with others. So it's cultures of inclusion and belonging, cultivating trusted relationships and collaboration and teamwork, not isolating. Not if you feel you're isolated at work, there's something wrong there. Then work-life harmony. I will really stress on this, and I do stress because even for myself, I have to remind myself that. So professional and personal roles can create work and non-work conflicts. So assure that there is a work-life harmony and balance, more autonomy on how work is done, make schedules as flexible and predictable as possible, increase access to paid leave, and respect boundaries between work and non-work time. How many times many of us, we might be out that door, we're about to leave, finished everything, and suddenly you get that call or from the nurse, and you know that you're about to leave and you're done, but you get that call that says, oh, this patient needs this, can you just put this order, or this patient came in, and a lot of times physicians will say, I can't leave, even if they want to. A lot of times physicians may come back and say, I'll just take care of that, knowing that they're going to stay longer and that's more work, the burden, they're tired. And even knowing that this is taking away from their family, but the long-term effects on that, because we owe it to our families too. You're a mother, you're a father, you're a sister or brother. You have other loved ones out there that are waiting on you or want to see you, and also for your mental health. So being able to say, of course, emergency situations, stat stuff, we're always going to be there. We have to do that. That's an obligation. But when it comes to things that can wait, or if it's that one thing that there is someone else that can take care of it, when you're out there, being able to balance that work life, being able for your mental health to be able to leave and get that, to de-stress and go home and have that balance. Because if that impairs your personal life outside and impacts that, that's going to impact your work life as well, and your overall sense of wellness. Mattering at work. So this is another thing with all, who doesn't want to feel respected and appreciated? People want to know that they matter to those around them and their work matters. So even simple things, just going, even when someone does say thank you or appreciate it. It sounds like it's silly, but a lot of times we take that for granted and it's not given to the person or even whoever it is, whether it's to nursing staff, whether it's to physicians, to even patients, there's social workers. We all have our jobs and we work hard, but taking that time, it lowers stress. No matter how stressed you are, that appreciation comes in, not for everything, but just making you feel appreciated can reduce that stress level a little bit. So that's part of creating a culture of mattering at work, providing a living wage. And again, this might not apply to everyone, engaging workers in workplace decisions, building a culture of gratitude and recognition, connect individual work with organizational mission. Opportunities for growth. So this is another aspect, and this may not, like I said, this is burnout. This may not be for everyone, but some people it's for growth. They want opportunities. They want to climb up. So organizations need to create more opportunities to accomplish goals. Not everyone might want to stay in that same role for years and years and years. They might want to teach, be involved in residency, be involved in administration. So providing that opportunity and providing training, education, mentoring, clear, equitable pathways for career advancement keeps the staff physician happy, right? Relevant and reciprocal feedback. And this is straight from Surgeon General, so I'm not saying it applies to all of us, but some of it does. So now we talked about burnout, addressing moral injury. So really, like we said, this is a problem with the structure, right? With the organizational medicine, what the problem is with us, the whole, not just the hospital, but the system as a whole. So structural reforms are necessary to prevent moral injury by removing the provoking situation, cultivating moral resilience, and remember, integrity. I added integrity because that is a key part, not just resilience, but the integrity. And by intervening at the level of moral injury. And I would say even a step before, identifying the moral distress and starting there. Organizations should be able to offer staff support, but the response to moral injury starts with the individual, by healing the moral wounds of medical practice. I'll give a story, and it's hard because we don't have time to sometimes step back and say, why do we feel that way, right? Why do we feel so angry with certain things, or something happened? Why? And recently there was a couple months ago, a situation where it came to a point where there was a patient, and psychiatry is never black and white. It's always a gray area. And unfortunately, we cannot keep patients overnight for observation in our hospital. And this was a patient that I did not feel needed inpatient psych hospitalization. She didn't want voluntary, her family's there. And this was a patient who I did not want to put in voluntarily because it's a whole process. We take away their rights, locked unit. Her husband was coming down, was going to take her. They were flying to their home, which was in another state. So looking at everything, I felt like this is someone that just needed 24 hours that I can give some medication, they would be fine. But it came to a point where I got a call because I kept them, and I got a call and it was like, why are you not discharging? Why can't? And it was, administration, they have to do, that's their role, is admit or discharge. And that was what was proposed to me, admit or discharge. And I'm trying to say, well, she doesn't fit for admission. And she would really benefit from just a little time, just overnight, couple of hours. But from their perspective, when I looked at it later, initially I was upset. And the answer was like, no, make a decision, admit. I called my chairman and I said, look, this is someone that can come back. If I send her home, she might end up back again, and that will make her miss her flight or change her whole life. It's just not right. And he said, I understand what you're saying. And he agreed. But he said, unfortunately, there's nothing we could do because this is the policy and this is how it is. So I said, fine, I'm not admitting her. I did not feel she needed admission. I spoke to the family. I sent some medicine. I said, I'm sending her home. And I said, if it gets worse, come bring her back. But other than that, I just took that chance and let her go. And she had a lot of support and things that was in place. But afterwards, I felt really upset. And I had to stop and say, why am I so upset? You know, why is it still bothering me after 24 hours? The next day, I was still upset. And I had to ask myself. And then going into that later on, I realized, you know, I felt like I was in my sense of what is right, what I wanted to do for the patient's best interest. What was right, I could not do that. And I was being told what to do, which was not aligned with what I felt was right for the patient. And when I looked at it later, I realized, you know, from their perspective, it's an ER. And if she's there and another patient needs that bed, I'm taking up that bed. So I was able to rationalize later and understand from their perspective that it's you know, someone else could become, we never know how the ER is going to be. It's unpredictable. And maybe if someone's come and needs that bed, and it might be, I'm taking that. So I taking that away. So I was able to let that sink in and rationalize, and I was fine. So that's where this is, to see that yourself, right? That's what it says about checking in with yourself when you get that upset, not just going on and seeing the next patient after next patient, figuring out with yourself, why did something upset me? And then talking to someone. It could be a colleague, it could be your chairman or supervisor, speaking to them. Because when you feel supported, even though I couldn't do and he couldn't do anything, just hearing that support, like, I agree with you and I know you're right on this, but, you know, unfortunately we can't do it. That itself made a difference. So that's the whole healing moral wounds, with starting with the individual. Clinicians need time and healing environments to care for sick and dying patients as well. Accomplishing this might require more support staff, clinical space, face time with patients, and lower revenues, which we know is going to be a difficult task. Health leadership can do its part to prevent moral injury by committing to clear communication with clinicians and staff. And I will emphasize on that. Communication is key. Not holding it in when you're upset about something and just saying, I'm going to quit, or I don't want to work here anymore, I'm being upset. But communication is really important. It's essential for building trust, and employees who trust leadership report lower job stress, greater wellness, activity participation, and a healthier behavior. Physician groups developed during COVID-19. Okay, so there were groups that were developed during COVID-19 to cultivate support for frontline healthcare workers. This was during the pandemic, and they did that similar to compare to the U.S. Army, who assigns to combat battle buddies, right? So they have someone because of the combat they do. So, and it was, I think it was Johns Hopkins, if I'm not mistaken, that did the similar thing, and they created this resilience rounds, which I think is a great idea. Resilience rounds is, and we can even call it integrity rounds now that we know, I like that concept of integrity. And what that is, and I spoke to actually with someone that would be able to communicate with the administration, that someone from administration should be assigned to do these rounds in different specialties of the hospital for psych, coming in there and checking in. It doesn't have to be every day, but coming in, checking in, saying, how are the physicians doing? How are the other clinical staff doing? Is there things that are upsetting you, or you feel that, you know, it's not being addressed? Feeling that you're heard, that you can communicate in a safe space and you're heard and listened to, and then, of course, seeing what they do to make a change. Each specialty like that, going around, it doesn't take a lot of effort to go to different units of different specialties in the hospital and getting that feedback, and then having a group, a work group that can be done to address some of these things. Because believe it or not, a lot of these specialties, some of them would overlap with the same issues and some may not. I will give another quick experience. When I came in one time, I remember there was something that had upset me. I won't go into details with the way that something was handled. And it was, I did bring it up to actually administration, because I've come to a point where I'm like, I'm comfortable enough to make an appointment and talk about something like that. I wasn't initially, I used to be fearful. And I was really happy because initially I felt like, okay, I don't know if this is going to go anywhere. I addressed it. A week later, when I came back to work, it was taking care of at least the steps. I saw the change and I just felt so happy knowing that the administration heard me. They heard what was upsetting me and did something about it, you know? And I think that's what's important. Sometimes that fear is there, like, can I go there? Because we see sometimes administration is something like, oh no, I'll get reprimanded. And every hospital is different. So, but just taking that step to try to bring it up, and you don't have to go directly, but whoever's your supervisor, bringing that up so they can then bring about the change. Now, the AMA made an article that recommended some steps to cope with moral injury. Communicating, as I said, with your fellow physicians about the circumstances contributing to moral injury, reconnecting with your calling, taking time to check in with yourself, all the things we addressed, and seeking support opportunities. As we are continuing a path towards a diminished pandemic, the stress of managed care, billing challenges, and other obstacles to practice medicine will always be there. Be aware of your wellness and ask for help when you need it. So communication, awareness. And then the last part of addressing moral injury is from the APA. And a lot of this actually came out during the pandemic. So some of this does not, it doesn't address the way moral injury is now versus the pandemic. And you can understand why this came out in the pandemic and why there was moral injury. There wasn't enough PPEs, there wasn't enough support staff, there wasn't enough safety for physicians and other colleagues and staff. There were people who died, there were suicides. So all of that happened. And that's where moral injury started coming out more, because there was not enough support. And physicians and other clinicians that work with us, they all felt like we were abandoned. And that's one of the times when there was a lot more. APA did come out with this 3-tiered approach. It's about during disaster and COVID-19, but some of this is still there and we can address, we could use this for moral injury. Tier 1, initial steps to reduce moral injury is to start a conversation about moral injury. That's the first step, right? And that's what this today is about. Starting that conversation, education, and then talking to your colleagues. Sometimes you won't get a full change that we want. It may still be there, but the fact that your colleagues feel the same, the fact that you can understand and connect with each other and getting that off your chest, what upsets you, that's a big deal during lunch, whenever it is. Educating healthcare workers about risk for moral injury, because this is not just something like, oh yes, I feel upset. It's not, it doesn't end there. Ongoing persistent moral injury leads to mental health issues, leads to substance abuse, leads to suicidal ideation. So it's not something like, okay, you know, we're complaining and that's it. No, this is something that takes a profound impact on physicians. Provide support for difficult decisions. So that's something that has to change within the system and the hospital, but it starts at the level of talking to your colleagues, speaking to your next supervisor, because as a group, if you feel something, you can bring it up to the supervisor who'll bring it to administration. Assign healthcare workers to consistent healthcare teams. Tier 2, during and after exposure. And again, this was during COVID, so it's not, a lot of it may not fully, cannot be done the same way now, but integrating discussions about decision-making dilemmas, moral injury into pre-existing education group settings. So basically having group settings where you can be discussed. There was check-in virtual group meetings for healthcare workers to check in with each other, as well as to receive education and support, and raising the topic of moral injury as appropriate and as a norm. This is something that's there for all of us. It's in every single state, every single hospital they work in, there's not at least one physician who goes through moral injury. And there's something that affects their ability to practice medicine in the way that it was intended to practice, and doing what they feel is right for the patient. And then, of course, identifying the resources to address the spiritual dimensions of moral injury, so faith leaders. Tier 3, measures that address the system issues that lead to and exacerbate moral injury. So this part is empowering and encouraging healthcare workers to speak freely about the stress they face at work and to advocate for their own health as well as that of their patients, like anonymous hotline, Dropbox forum, or like I mentioned, the resilience round. Leaders must be prepared to respond transparently and proactively to feedback. So this is the last part that, and I have the questions that were asked of me. And this is during the pandemic. I think it might have been India or Bangladesh, I'm not sure, but around them is all the cremation of bodies. So you see the ash, and it's a family member who's clearly, you know, distraught. And you have a healthcare worker during that time when we were doing, and we're not talking about safety, but, you know, despite all that, where you were supposed to maintain distance and all, they realized what was humane, at that point, that this person needed comfort and support. And that's what that person did. The healthcare worker gave that, because you're first and foremost, like we said, we come into this profession to heal, come into this profession to do what's best for our patients, their families. And that's what I felt like this picture is. We go around, and in our world and in our profession and in our hospital, we may have all this fire and ash and things there. But at the end of the day, feeling that support, the communication, and keeping the patient needs and making sure we're heard, and we would be able to go on. So I'm going to go into our questions. One thing I would say is, and it's in the question, is that, there was a lot of here and there was physician about a suicide that happened. There was one that particularly stayed with me, and I felt so sad. And I remember it was an ER physician. As you know, during the pandemic, it was all, everyone was affected, all the physicians, but ER specifically, you had the pulmonologists, like ICU, all of that, right? The first and front lines. And there was one physician in the city, I think, she was an ER physician who had committed suicide. And everyone said it was burnout. And yes, burnout is there, and I'm sure she went through burnout. But once this moral injury came in, I started to think, was it only burnout? Because yes, there was a lot more volume patients, but it wasn't just that. Here she was, she probably didn't have, as we all did, enough equipment, patients dying left and right, making decisions about who to go to, who not to go to right away, not being able to, what we do is we go into the savior mode, right? As physicians, it's always to help, to save, and losing that control affects your moral injury. So when her and many other physicians, there were some other ones that committed suicide, residents. And that's where I wonder, was it just burnout, or was there moral injury? And I'm pretty sure that must have been there. The guilt, the shame, even though it wasn't her fault, the guilt, the shame, and all of that must have followed in, the despair that may have drove her to unfortunately end her life. So I'm going to go into that with the questions that were given first that people had. And then if time permits, I will take more questions. I know we have about 12 minutes. So are there parallels in other professions, moral injury? Yes, there is definitely, but I think it varies. And overall, like I said, the main parallel is that we all feel the same connection. Why we came into medicine is the same, right? Our ways of healing, our ways of taking care of patients, the ways that we do it is different in each specialty, but we do have parallels, some more than others. For myself, I feel like psychiatry can, I feel like we're more in line, we can understand ER physicians. And I see that because a lot of times what we face, they also face. Violence from patients, families, verbal, physical, the other challenges that they face down there. I feel like we can understand each other more. But versus a surgeon and myself, we're very different with psychiatry and surgeon. And we had a conversation actually where when I gave this talk for the GME, there was a surgeon on, and he said the challenges he felt for the moral injury. And it was very different from what psych felt. And those challenges were more with the restrictions because of authorization, the procedures, the obstacles he had to go through to get procedures done, not being able to help the patient as best because of all these other things. And for psychiatry, it's different from that. And when I said my perspective, I don't know how much they would be able to appreciate that. But there is parallels, and then there are things that are different. But at the end of the day, it's both. When it comes to moral injury, it's what affects us is our sense of self to be able to heal or to give the best possible care to our patient, doing what's right to provide that. How does moral injury differ from military and physicians? We did talk about that, so I'm not going into details for that. The third one, I'm not the best person to talk about this, but I have had a few from colleagues about moral injury in relation to abortion bans, what I've heard that, and also I'm on a forum where there is physician moms, and I've seen a lot of OB had talked about that, and I could see what was coming out there was moral injury. They were taught and trained a certain way to do what's right, and everybody's sense of what personal choices are different, but as a physician, they were talking about things where it could affect the mother's life or whatever the choice. And I saw all those things where they were talking about moral injury, basically what they felt when this came out, and how that was the restrictions when they can't provide the best care that they felt for the patient to help the patient. And what was affecting them was the moral injury, the anger, the despair that they felt was evident and was seen. So I can't talk too much on that, but definitely it was there. In the colleagues I spoke to, the frustration and anger that I can hear from them, and then in the forums and all that I've seen. Is burnout and moral injury associated with higher suicide risk and rate of medical students and physicians? And suicide risk in terms of ideations, yes. Attempts, not enough studies or there's no studies to show that. What I will tell you, there are some studies out there. And what I saw was that burnout in these studies in medical students, what they saw was that 50% of the group of the students they interviewed had reported burnout, out of which 10% reported suicidal ideations. And from all that, 99% recovered from the burnout. And when they recovered from burnout, the suicidal ideations went away. So there was, at the end of the studies, that there was a link to burnout and suicidal ideations. There was no attempts, but there was suicidal thoughts, which itself is very scary. There are other studies in residents. There's a lot with burnout in medical students, residents, and physicians. Physicians also, there's an estimated 300 physician deaths by suicide per year in the US. It's not, this is not the study based on burnout moral injury, it's multiple factors, but I'm sure in that there is burnout and moral injury. So there's 3, out of which males have a 40% higher than the general population for suicidal rates. These are like actually trying to attempt suicide, and females 130%, female physicians. So to answer that, there is a higher risk of suicide, absolutely, because there's a higher risk of anxiety, there's a higher risk of depression. There is one study that, because I was looking at moral injury, there was no studies except for one. I think more will come out now or might be in the works. It came out in April 2023. It was from China, but it was about moral injury and suicidal ideations in healthcare professionals. So it wasn't specific to physicians or specific to just residents or medical students. It was in general. And they did see that moral injury did have an increased risk for having suicidal thoughts. Again, not attempts. But they said at the end that more studies need to come out. So the next one, strategies support faculty or residents struggling with burnout and moral injury. So we talked about that. A lot of that is support groups that can be created, especially with residents and faculty, having that group. But and there's a question later about this too. I think it's the next one, which talks about medical students first and second year medical school. This is tied in with residency and medical school. I think one of the things for anyone that's in GME or program directors, assistant program directors, or in just teaching and residents and mentoring them, one of the things that I would suggest is that, which a lot of schools are doing now and programs, is making sure that there's a process group, especially for that first year resident. That first year resident who's transitioning from medical school, and even in medical school, to have that a process group in the first and second year, because we all know the transition from high school to medical school is difficult, and it's so sudden from, high school, college to medical school, and then medical school to residency, and from residency to being attending are very different. And there needs to be a process group in that early training period and during medical school. And that process group is with the mentor, addressing their issues, their thoughts, making it a safe space for them, and didactics. And even for fourth years, as a program director, I am incorporating that for the new program and making sure fourth years as well, because they are getting ready all the worries and stress that they have as starting off as an attending, but also a didactic series that addresses, I've definitely put that in our program, to address moral injury, burnout, and a lot of programs are starting to put that in as well. In medical, it should start in medical school, definitely, so that they know how to address that, because it does start there. What can organizations help instead of causing? We talked about that. How they can do that is getting communication, listening, making physicians feel that they're heard, and then actively taking the steps to what they hear, maybe the resilience rounds, and then acting on it. Maybe not everything. We have to have expectations to know everything will not be answered, but at least to know that some changes are made. That makes a big difference. We discuss the impact of seeing your learners subjected to discrimination from patients and families. This might be an ER attending or a psychiatrist, because we go through this, a lot of this. And this is very common. That's a whole nother topic that is also very dear to me, about the violence towards physicians and discrimination from patients, families, sometimes even staff. And that, what that does is, the impact is moral injury. One of the things, like we said, when you know you're trying to do what's best for the patient and trying to do no harm, but in return, when they give you a negative feedback, they complain to patient advocacy, the discrimination that you get, the ratings that you get, how that affects your moral injury, because it starts to question if you did do the right thing, the anger, the despair, what that does. So that's the impact. I know One of the things is that, for example, like we see in psychiatry, and you might see in other fields, which is the benzos. I know in other professional, in other specialties is the opioids, even in the ER, they don't get what they want sometimes, and you know this is not what they need right now. So being able to, when patient advocacy calls you or when administration calls you, it's not like just fix it and can you just give it to them or fix it. Taking a step back, I get calls, can't you just discharge a patient? This is a suicidal patient, and I tell them no. Stand my ground, because if I don't and I give into that, at the end of the day, it's going to be my license, or I'm the one that may end up in court, or I may be the one that ends up with moral injury. I stand my ground to say, no, I cannot. If I can, of course I would. I cannot, because, and support your statement, support it, XYZ. Patient had a suicide attempt a couple of months ago in the last 1 year. Patient told so-and-so, this is my thing. She told her family she's going to hang herself. Patient has a cut, blah, 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 whatever it is. All this, I lay out my steps to say, this is why I cannot. And guess what? I don't get any more pushback. I'm told, okay, I may get a call the next day again. Can you discharge the patient? I'm working on it, right? But safety, and I always say patient safety. So backing up your statement, why you chose a certain treatment, why you're standing by that, and backing that up with, at least that you tried to do what you felt is right. And I'm not saying it will always work, but most of the time it will, when they hear why you're doing it, rather than just fix it and get to it and you feel like there's all this pressure on you. Being able to stand your ground and addressing it with points. As we say, it's almost like when you have evidence-based medicine, right? So to treatments and stuff, when you go back to that, same thing, supporting it. Okay, I'm so sorry, it's 3 minutes. So this one, physicians are busy. How do you convince them to attend a program? I don't think we should convince anyone. If someone is going through burnout or moral injury, you educate them to say, this is available, this is there. I think you should attend this because this is what I feel, and letting them know it's there. It's up to them. It's just like when families ask me, can you get them to stop using drugs? I said, no, they have to make that decision. I can help and give support, but they have to choose. So the same way, do you create a culture of positivity? This was a good question. When your supervisor is threatening and volatile, very difficult. And I'm really sorry for the person that may be in this situation, because it's a difficult situation. What I would say from my own experience, and I think other people here could probably, your colleagues would probably be able to help you too. But what I would say is the first step, chain of command. I always say that, don't jump to administration anymore, just follow the chain of command. And I think it's the way you address first. You can try to address it differently. I feel like that always works. It's like when there's an aggressive homeless person, the moment I say sir, because everyone likes to be respected, I say sir, I could see their face change, because I'm like, no one's probably addressing you as sir or ma'am, So I'm like, sir, what could I do? It changes the tone. So starting with letting them know, rather than saying, I think that we need to do XYZ, there's no culture of positivity, or we need to do this, versus, I start with the positives. I feel on this unit, these are the positives that I see on the unit. And I'm really, I think you're doing a great job with that. However, I think there's more things we can do to change that. So it's we as a group, not like I'm putting it all on you and blaming you, but we can do to make this a better place to work. And again, I'm not saying that work because I don't know how the supervisor is. But a lot of times if it's a good supervisor and they don't feel threatened, they will listen and they will take that feedback, versus when they feel like saying, or you're saying, I'm not doing a culture of positivity, this is not a safe place. So addressing it, the way you address it, the way you approach it, and then if it doesn't work, then the next step would be the chain of command. But always keep in mind, it's different for different people. Someone who's about to retire, addressing this question versus someone who's beginning of their career is very different. Are there any didactic speakers recommended to this? There's a lot of topic out there. As I said, the main people was Dr. Wendy Dean and Dr. Talbot. They actually have a website, Moral Injury. If you go in, they're doing a lot of things that I actually wrote to them, but I don't think they're trying to ask for like volunteers and people, and there's a lot of things they're doing. So you can actually go onto their website and take a look at it. I'm sorry. Okay. And how did we begin to make a mistake moral injury burnout? I really think it's the pandemic. Moral injury has always been there, but a lot of things we were able to just like brush it under the rug and keep going, because it impacted us, but it wasn't to this degree as when the pandemic happened, when a lot of things, it really did impact moral injury, because these were things that we could not do. There was this loss of control, and patients were dying. We couldn't do what we felt we came into this profession for, and there was a lot of restriction because nobody knew how to handle this. So I think that's when people started mistaking it for burnout. How do you navigate these terms? As I mentioned, for resident, it's the same thing. Process groups, didactics. and openly making it a norm, that this is a norm, not something to be stigmatized. If you see a lot of applications for jobs, board certification, they're asking about mental health and wellness as if it's a stigma. It's not done in a positive way. So creating it as keeping it as in your workplace as a positive thing, seeking mental health. If you have anything with burnout, moral injury, it doesn't mean you're weak. It doesn't mean that you should view yourself as that, or the program director is going to see you as a weak person. It just means you need more support, and that's what we're here for. Okay, I think I've answered all that. I know there's a lot of stuff in the chat, but I'm not sure if I can go through that at this point. So Austin, thank you so much for everyone that attended the seminar, and I'm going to hand it over to Austin.
Yeah, thank you so much, Dr. Abraham, for this great presentation, and to all who joined us. If you have any questions, please contact us directly at aogme@acom.org. This concludes our webinar. Thank you again to Dr. Abraham